I got to say that when I decided on the topic for this podcast, I didn't choose it because I had gotten too many consult requests for altered mental status, or even too few. Honestly, I don't know the ideal number you should get. But I work at a tertiary care center with over 900 beds, so a lot of these patients are sick and land on my consult list. In today's episode of BrainWaves, I'll talk about what kinds of patients belong on this list and what patients don't. But before we get started, a quick word from our sponsors.
This episode was powered by Paul Hodge, a financial planner who works specifically with medical professionals. He has helped members of the BrainWaves podcast grow their wealth and manage risk. Learn more about how to secure your financial future at paul-hodge.com.
First of all, what is an appropriate neurology or psychiatry consult for altered mental status? When do the brain doctors become the specialists here? I can't say that I know the answer to this question, but hopefully this episode will leave you with some tips on what's an appropriate neurology consult request and what's not. This gets particularly difficult in the ICU when half of patients experience altered mentation at some point. And nearly 85% of patients on a ventilator can develop altered mental status. Should a neurologist be consulted for each of them? Probably not, right? But we aren't going to get into the specifics of ICU delirium today's talk. We're going to talk more generally about preparing and returning a neurology consult. In that light, I've come up with a few simple rules. Rule number 1. Don't request a consult to have neurology on board. Have a specific question in mind. In general, I think of consults like a cry for help. Some other care provider is dealing with something they feel uncomfortable with, and they need your help with it. I know this because I'm constantly calling everyone else for their help managing the remaining organs below the neck. Let's get to an example. Say you have a patient with multiple medical problems, and you've hit a roadblock in the management of the patient because they're altered. Think how a neurologist can specifically help you besides just being on board. I mean, what can go wrong with this situation? Well, a lot of things, actually. In the absence of an obvious question, a consultant will lack direction in which to proceed with the patient. The consultant might recommend an extensive battery of diagnostic tests, imaging, and invasive studies to answer any neurologic question imaginable. Or the neurologist might neglect one key feature for something less concerning, but maybe more obvious to you. Once I was called to be on board for a patient in a dialysis unit. He'd had multiple medical problems and was confused during hemodialysis one morning. When I examined him, I found his right foot was also weak. I thought. I guess that's what they called me for. So I recommended an EMG and a lumbar MRI to work up his peroneal neuropathy. But the primary team didn't care about the foot drop. Nope, just the delirium. So I talked with the team for a while about it, and given the patient had also had some new mild hypotension, some back pain, and a 2-gram drop in his hemoglobin, we decided to image his pelvis. It turns out he had an iliacus hematoma that was compressing his sciatic nerve, causing the foot drop. So I got the answer to my question about the foot drop, the team got an answer to their question about the delirium, and we probably could have figured this all out much sooner if only I'd gotten a consult question before seeing the patient. Rule number 2. A history is worth 1,000 words. Timing is critical here. There's an oceanic difference in the causes of altered mental status between a patient who was normal 2 hours ago and who is normal every 2 hours. An acute change in behavior, meaning a change over seconds to minutes, is concerning to me for only 2 things. A vascular event like a stroke or a hemorrhage, or a seizure. Review the patient's vascular risk factors, hypertension, diabetes, tobacco use, to see if stroke is a possibility. Is the patient on an anticoagulant? Do they have a history of epilepsy, of brain infection, loss of consciousness, substance abuse, and so on? Things that can lower your seizure threshold. Often, the altered patient won't be able to tell you about the timing of the event, so ancillary history from bystanders or family members is important here. Say the altered mental status developed over several hours or days. Now I'm thinking of something more systemic, possibly metabolic, infectious, or inflammatory. Any change in mental status that progresses over days or weeks is now exiting the realm of altered mental status and encroaching on the rapidly progressive dementias, tumors, toxicities, and other diagnostic categories. Now that we've considered when the patient became altered, next consider how the patient is altered. What is the delta of the change? If your patient was a young and healthy woman who came in with 2 weeks of visual hallucinations and personality changes, then I'm going to worry a lot about toxic, metabolic, infectious, and inflammatory causes of encephalopathy. If your patient's an elderly woman with dementia and she's been dependent for all ADLs, I'm not going to panic as much if she's now become forgetful of where the channel changer is. But say this elderly woman now has visual hallucination. Now I'm wondering, do they have dementia with Lewy bodies? Have they tried new medications? Could this be a seizure or related to an underlying mass or a stroke? The entire differential has changed. Rule number 3. Rule out acute neurologic emergencies. I can't stress this enough, especially for trainees. And by neurologic emergencies with altered mental status, I really mean stroke or hemorrhage. A lower state of arousal with or without eye movement abnormalities or facial weakness is concerning for a brainstem or top of the basilar infarct. An intracerebral hemorrhage or large stroke of the cerebellum can produce subtle neurologic symptoms, but swell to the point of occluding the fourth ventricle, causing obstructive hydrocephalus. And if you're not confident in your exam skills as a neurology or non-neurology provider, call the consult for this. You don't want to delay treatment for a patient with an acute cerebrovascular event. Last year, I saw a young woman for newly diagnosed cerebral venous sinus thrombosis. She was a young woman, history of lupus, on and off anticoagulation for a prior venous thrombosis, and she presented with headache, confusion, and intermittent impairment of visual acuity. My team got the consult 3 or 4 days after she had been admitted, long after the patient had a normal head CT and a normal lumbar puncture, failed traditional analgesics and fluids, and the MRI and MRV eventually confirmed a thrombosis of the left transverse sinus. And that's when our consult came. Deferring the neurology consult for this long no doubt led to unnecessary invasive testing like the lumbar puncture. Deferring the neuro consult also delayed the acquisition of more pertinent imaging, and this could have left the patient with significant permanent disability from intracranial hypertension, venous infarction, associated intracerebral hemorrhage, papilledema with vision impairment, and so on. It's because of cases like this that I get angry about providers holding off on the neurology consult. Besides things like stroke, other neurologic emergencies can be excluded with basic exam and diagnostic testing. A fever can impair the alertness of any adult, no matter how healthy they once were. And in kids, fevers can cause seizures. Hypotension and cardiac arrhythmias may impair cerebral perfusion. A capillary glucose level is a quick and easy test, and both hyper and hypoglycemia can cause altered mental status with and without focal deficits. Sometimes a rapid shift in blood sugar can also lower the threshold for a seizure event. In a patient with possible organ dysfunction, asterixis, or fluctuating consciousness, go ahead and get the metabolic panel, the liver studies, and an ammonia level. Hyperammonemic encephalopathy can cause severe cerebral edema and coma if not managed swiftly and appropriately. Rule number 4, our last rule. Be the first person to do the neuro exam. I know it sounds dumb, but I'm completely serious here. I've been consulted once by a neurosurgeon about a question of Guillain-Barré syndrome in a patient with severe lumbar stenosis. When I asked what the reflexes were, I guess I shouldn't have been surprised that the surgeon didn't test for them. I mean, really? You didn't even test the reflexes? A neuroconsult is not meant to be used for a basic neurologic exam. And the same goes for all other specialties, except maybe OB-GYN. But if you're calling vascular surgery for a patient with suspected compartment syndrome, you better have checked for pulses. And if you missed the pulses, you better have gotten the Doppler. As far as the neurology exam goes, do your best to get a basic sense of the patient. The neuro exam traditionally starts with the mental status, and surprise, it's going to be altered in your patient here. But importantly, I think every provider needs to be able to distinguish aphasia from delirium. By definition, delirium is a systemic disturbance of the nervous system function that causes fluctuating levels of attention and alertness. By contrast, aphasia is a very focal sign, often localizing to the dominant frontotemporal or temporoparietal regions, in which there's a specific and often persistent language deficit. It's usually pretty obvious when a patient has an expressive aphasia. They either can't speak or they have trouble vocalizing. But you can imagine this would be difficult to assess in an intubated patient. So assessing the patient's written language can be helpful here. It's less obvious when there is a receptive aphasia, meaning they have trouble understanding what's being spoken or shown to them. This is easily mistaken for delirium because the patient won't be following commands. Unlike the delirious patient, however, the aphasic patient should be alert and attentive, unless there is another reason they may not be awake during your exam. But the language they produce will be abnormal. A delirious patient may produce less speech, and similarly may not follow commands too well, but the inability to follow commands should be proportional to the level of consciousness, so try to distinguish the two. And if there are any other abnormalities on the neurologic exam, abnormal facial movements, asymmetric strength, sensory loss, and so on, then yeah, call neurology to help you localize the lesion and work toward the diagnosis. They're there to help. I was just hearing the story about a patient who came into the ER unresponsive, and the only abnormal finding that was obvious on the exam was pinpoint and unreactive pupils. One of the easiest things you can do for a patient like this, who is acutely unresponsive and has pinpoint pupils, is to give them a trial of naloxone or Narcan. Opioid overdose is increasingly common, and it's even being called an epidemic nowadays, so have a low threshold to treat it. But if the patient with pinpoint pupils does not respond to escalating doses of naloxone, as your hospital's protocol may be, that's when you should consider other conditions that can cause altered mental status and meiosis. For instance, a bithalamic hemorrhage or infarct with compromise of the hypothalamus. Remember, this is where the first order neuron lies of the 3-neuron pathway for Horner syndrome. Loss of your thalamus will cause altered mental status, and loss of the posterior hypothalamus causes the meiosis. Strokes affecting the pons can also affect alertness and cause meiosis. And lastly, pinpoint pupils may be explained by neuroleptic or cholinergic toxicities, so checking for rigidity and fever for neuroleptic use, or diaphoresis, emesis, and diarrhea for cholinergic toxicity should be some of the elements in your history. Once I was asked to see a middle-aged woman who was not participating with physical and occupational therapy as much. She was recovering from a mitral valve repair a few days prior and was feeling otherwise well. I got the sense from the primary team that she wasn't really all that motivated to work with these providers, so the surgeons asked if I could come by and evaluate her for a hypoactive delirium. After a few minutes of speaking with her, I realized she wasn't even making eye contact with me. She was tracking my voice around the room, fully engaging in our conversation, but not really looking at me. Not in my eyes, anyway. I was a junior resident at the time, so I thought I would just ask her, "Can you see me?" In response to my question, she said, "Of course I see you." "What color are my glasses?" I asked her. She said, "Oh, I love your glasses, Doc." I don't wear glasses. Much of the neurology I've come to learn is figuring out ways to distinguish true neurologic deficits from false ones. Often this does mean tricking your patients in some way. Cruel, I know, neurologists, we're the worst. But by tricking her, I was able to figure out she couldn't see. I had read earlier that patients with cortical blindness are unaware of their deficits, but they're still unable to perceive their visual surroundings. It's called Anton syndrome. The optic nerves work perfectly well, so the pupils will respond to light, but they will not perceive it. Her pupils responded perfectly to my pin light, but she did not blink to threat, which meant her lesion was cortical and bilateral. I rolled her down to the CT scanner immediately, where we confirmed my suspicion: bilateral occipital lobe infarcts. I think that if you do the neuro exam, you'll find the patient's underlying sepsis or multi-organ dysfunction or sedating medications may not always be sufficient to account for their altered mental status. Or the neuro exam can be used to confirm your suspicion of it. Occasionally, ancillary diagnostic testing like a routine EEG can be helpful in these circumstances. An EEG may be able to identify diffuse slowing or triphasic waveforms, as we see in toxic or metabolic encephalopathies. An EEG can show you excess beta waveforms in patients on too many sedatives, or it can show you frontal intermittent rhythmic delta activity in patients with a metabolic disturbance or rising intracranial pressure. Sepsis alone can cause encephalopathy, but this typically improves with antibiosis, so treatment in this instance can be your diagnostic test. It's critically important here to be aware of renal function because some drugs, particularly cefepime, can quickly turn your calm and quiet patient with a UTI into a delirious aggressor with encephalopathy. And nearly any medication can precipitate an adverse behavioral response in a hospitalized patient. While you may think that giving your agitated patient a small amount of lorazepam may calm him, a small proportion of patients may have a paradoxical reaction to it. Benzos may actually make them more agitated. And you think an atypical antipsychotic may help your older patient with delirium? Not if they have dementia with Lewy bodies. Dopamine antagonists can worsen cognitive symptoms and behavior in patients with dementia with Lewy bodies. So that's all we got for you this week. 4 rules about the altered mental status consult for every practicing provider. I'm sure I could come up with more, but I think 4 is good enough for now. Rule number 1, neurology doesn't need to be on board. Have a specific question and ask it. Rule number 2, get the history. Rule number 3, rule out the neurologic emergencies. Rule number 4, be the person to do the first neuro exam. Thanks for listening to the show this week, guys. As always, we'd love to hear what you've got to say. Please give us your feedback on iTunes. Check out the website at brainwaves.me. You can follow us on Twitter at brainwavesaudio or Instagram at brainwavespodcast. Music courtesy of Andrew Sacco. I'd also like to thank Erica Mejia for her assistance with the production, and Kingsley for always trying to make more noise in the background. That was a good one. I'm Jim Sigler for BrainWaves. We'll see you next time.